Hello. I have chosen to share with you a patient that I've had several times over the course of my clinical rotation. Here at my hospital, we have CCU, which is the coronary care unit. So we have a lot of patients who come in for heart surgeries, and then we get them back on the vent post-op. And I wanted to share how a patient who had a mitral valve replacement turned into ARDS. So a little background information. She's a 63-year-old female, about 5'5", 180 pounds. She was admitted for surgery on June the 8th, and she is a full code status still as of this day. She needed a mitral valve replacement. She just had some mitral valve stenosis, so she just needed to have that replaced so that she could get adequate heart flow and wouldn't compromise the rest of her comorbidities. So, patient history, she was referred to her to a new cardiologist from her primary care. It was recommended that she have the mitral valve replacement. She came in for surgery on the June 8th. Post-op, her surgery took, I think, about 4 or 5 hours, and then they immediately come back to the unit, bagged, and then respiratory takes over, puts them on the vent. We get an ABG, make sure that her settings are correct about an hour later. And then the cardiothoracic surgeons like for them to be woken up within 4 hours. We tried to within that time frame, but she was very groggy. She could respond to some commands, but she just wasn't passing those tests that she needed in order to extubate. So we left it for the night shift to extubate her. I had her again the following day for my second day of clinical that week. She was alert, she was awake, she was responsive. We were doing Q4 neb treatments on her, and everything looked like she was recovering well. And then over the course of the next 3 to 4 weeks, she slowly started to decline, and I'll get more into that just a bit. So some other background information, she does have a history of high cholesterol. She does have type 2 diabetes, which also led to her left below the knee amputation as a result of that. She does have a history of COVID, high blood pressure, and before she went into surgery, she was a current smoker. She said she smoked about a pack a day for the last 30 years or so. So moving on, I wanted to show a timeline of kind of how she declined in her general appearance over the course of the few weeks. As I mentioned before, she was awake, alert, 1 day post-op. She had minimal pain from her surgery. Her vitals, were within normal limits, except for SpO2 was a little low. She had a slight temp. Breath sounds were a little diminished, which is not unusual coming back from heart surgery, especially with her existing comorbidities and being a smoker as well. When she was extubated, she was put on a 4-liter nasal cannula and was holding steady then. Then over the next couple of weeks, while she was awake, I could tell she was fatigued. She didn't feel good. Her pain was controlled, so it wasn't that was bothering her. We start to see an increase in her vitals. Heart rate's jumped up. Respiratory rate is up. Blood pressure's up. You'll see that her O2 sats were about the same, but that's only because she was up to a 10-liter pendant and a BiPAP, so we were alternating those. Her tip did come back down, and although her breast sounds were still diminished, she started to develop some crackles, and that was due to the fluid that was starting to accumulate in her chest cavity, which is why she needed the additional oxygen supplement. She just was starting to not oxygenate very well because that fluid was starting to build up around her lungs, so she wasn't able to breathe as well. As of today and recording this, she is now on a ventilator. She's been sedated and paralyzed because she is on pressure control. She has also been put on ECMO and dialysis as well. While her vitals remain stable at this point, it is due to her being regulated by that ventilator. Heart rate's on the lower end. You can see her respiratory rate is very high though at 30, and we have it set that way because of the doctor's recommendation. She's getting low tidal volumes with high respiratory rate. Blood pressure is low. I wasn't able to get a temp on her that day, but I don't think they were worried about her having an ongoing infection. While her O2 sats are at 96%, again, that is due to it being regulated by the vent and also from ECMO as well. Breast sounds are now coarse and crackles. She also has blood tinge secretions, heavy blood tinge secretions. So here I just wanted to show a range of her abnormal lab values. Way back on June 10th, a couple of days post-op, we're already starting to see that she has a high BUN and EGFR, which is an indication of poor kidney function. She also is starting to see a decline in her hemoglobin and her platelet count, and her neutrophils are high as well from a bacterial infection. Her INR is a little high as well at 1.4. About a week later, we can see a significant jump in her BUN up to 85. Her creatinine is also high as well at 2.2, and we can see her EGFR is getting lower. She's also developed a high white blood count due to a slight infection and inflammation. Hemoglobin has dropped down to 7.4 as well. Also, her red blood cell count is 2.6, and INR has jumped up to 1.5. Fast forward to the 24th, you can see her BUN and creatinine have jumped up a little as well, and her EGFR steady declining. Again, her white blood cell count is up from 11 to 17. Her hemoglobin is back up, but you can see her platelet count has declined from 62 to 39. And her INR has jumped up significantly to 2.2. Again, you'll see on fast forward a little bit further down the line, her BUN is back down almost in half, and her creatinine is down as well, but that's still high and elevated given her condition. EGFR is bumped back up a little bit, but is still showing poor signs of kidney function. Her white blood count is 11.3, not 113. I missed the decimal there. And her hemoglobin is holding at 8.7, and platelet count is up a little bit at 65, and her INR is back down to 1.4. Alright, so here I wanted to show a progression of her ABG based on the type of oxygen supplement equipment she was on. So on the 13th here, this is when she was on the BiPAP. You can see her pH was a little low. CO2 mostly normal, but her PaO2 was significantly low. Then we'll jump to when she was on a 15-liter pendant. She's slightly acidotic here with her pH a little high. PO2 is a little high as well, and still her PaO2 is very low. And then you can see her bicarb is up as well here. Then we'll fast forward to 2 different days where she's on the vent. You can see she's increasing in the pH and decreased on the PaCO2 there. Her PaO2 is within normal limits for her, but you can see her bicarb is up as well. And then fast forward to the following couple of weeks. She's been holding at this, ever since she's been intubated. She does get Q4 ABGs now, and we basically do that so that perfusion knows how to change her ECMO and make any manipulations on that machine for her. So here I wanted to show the progression of her chest x-ray. She gets one pretty much daily now at this point. Back on the 12th, she had an increasing right pleural effusion with interstitial edema, then progressed to bilateral interstitial edema and pleural effusions on both sides as well. Very dense, starting to see that consolidation forming. Then on the 27th, she has very diffuse opacities throughout her lungs, pleural effusions, and her heart is completely obscured on the x-ray. You can't see it at all due to the dense consolidations. Then we'll jump to July 13th. This was her most recent x-ray that I looked at. You can see she has dense bilateral perihilar consolidations that are just not going away despite all efforts. So I wanted to talk about how she went from having a MVR and how she developed and started declining and ultimately leading to ARDS. So as I mentioned before, she came in on June the 8th for her surgery. And then within the following weeks, we see where her O2 starts to drop and she needs increasing efforts from equipment in order to keep her from going into respiratory failure. Usually when people are extubated from heart surgery, we put them on either 4 or 5 liter nasal cannula. And most often they remain stable on that until they can be weaned all the way off. She obviously went in the other direction. She went from needing the nasal cannula to a pendant. She was even put on Vapotherm, which is like a high flow nasal cannula as well, alternating between those 3 and BiPAP. And then ultimately she needed to be intubated to prevent her from going into respiratory failure and needing to maintain her airway as well. So what led to this basically was her increasing edema around her lungs. Her chronic kidney disease was a contributing factor to this. She has a nephrologist that follows her, so she has multiple specialties following her care. And as I mentioned, she just had that increasing pulmonary edema. Even though she was being given Lasix, overall it just wasn't helping, and the fluid was building up, causing her lungs to fail, and she was poorly oxygenating systemically, which led to her needing to be intubated. She became very lethargic, tachneic. She was using accessory muscles in order to breathe. She had poor urine output. She was going into AFib as well. And ultimately, after they got an ABG, it resulted in her getting intubated, put into pressure control mode, and she also got an NG tube placed as well. So after she was intubated, she was bronched by the pulmonologist, and through a combination of tests, with the bronch, the x-ray, and basically how her lungs were functioning was consistent with ARDS. Then she was placed on BV ECMO. They started antibiotics because she did have a little infection that came back from the culture in the bronch. And they also added vasopressors as well. So based on the decline of her condition, she's very, very chronically ill. It's very severe. And, she's in acute respiratory failure with hypoxia and hypercarbia. Ultimately, as a result of that mitral valve replacement and a combination of her comorbidities, she just did not have a good outcome, with her diabetes. She was already had a history of diastolic chronic heart failure. She developed encephalopathy. Now she's in chronic kidney disease, stage 3. She's had multiple UTIs, and from her bronch, she developed that Klebsiella pneumonia as well. So just a combination of all these things ultimately led to her decline. That fluid just accumulating around her lungs, causing her alveoli to collapse, leading to ARDS. She's on several interventions. She's requiring mechanical ventilation. She's on ECMO. She's on CVV-HD, which is, dialysis for her kidneys. And she even has that central venous cath placed as well, so that they could draw labs, distribute medicine, that sort of thing. So she's on a lot of different types of care that are ultimately keeping her alive. Respiratory medications, she's still on Q4 Duoneb. We're giving this to her, to help prevent any bronchospasms, help clear out any wheezing she might have or develop. She does sound very coarse, so we are giving her that through the vent as well. Non-respiratory medications, she is getting albumin, amiodarone. That's to help with her dysarrhythmias and any heart malfunction she's having. She's getting her insulin as well. I did mention before that she was a current smoker, so they are giving her nicotine patches to help with any withdrawals that she might be having. She is on Levophed, vasopressin for sedation and paralyzation. She's on propofol and fentanyl, and she's also being given IV nutrition as well. She was given antibiotics for her infection, but it has since cleared up, and she's no longer on that as well. So expected outcome in the short term, she will basically stay on the vent. We need to monitor her peak pressures and her tidal volumes. Right now they are very low, and her pressures are hanging out around 35, 38, and also at that high respiratory rate as well. Right now, the pulmonologist that is following her is fine with that as long as she stays consistent. She will need to stay sedated and paralyzed. She will continue to need ECMO, dialysis, and Q4 ABGs to monitor that, any changes to her ECMO as well, and we will still give her that Q4 Duoneb as well. In the long term, unfortunately, I do not see a good outcome for this patient. Prognosis is very poor, with her basically being kept alive on the vent, ECMO, and dialysis, and not showing any signs of improvement over the last 3 weeks ever since she's been on these interventions. She'll likely either need to go to a long-term care facility or will need to be terminated, unfortunately, and turned over to palliative care or hospice. This is due to her basically having consistently low platelet counts. She has a astronomical high BUN creatinine and a low EGFR. She's still maintaining those high peak pressures, low tidal volumes. She's already developed an infection, and in the long run, she's just susceptible to getting more UTIs, more ventilator-associated diseases as well. Also on her ECMO, the sweep has to keep getting increased, and basically that's a poor oxygenation status. So this comes from Desjardins, our clinical manifestations book. This just basically shows the clinical presentation and how she actually presented when I saw her last. And that is my source reference right here. The rest of all my information either came from the doctors, the nurses on staff, and the RT as well when I was asking a lot of questions about her.